Okay, we're going to get started. I know people are still coming in and grabbing pizza. That's fine. But in the interest of time, we give our two speakers enough time to speak because we have a very special session today. My name is Chris Martin, and I'm the Director of Education here at Royal Victoria Regional Health Centre. And this is our second round in October. And the reason is we have a very special topic that we had to put in. It's an important topic that affects every female at some point, and is, as you're going to hear, underappreciated and undertreated. I'd like to thank Mitch Green, Alex Laycock, and Amy Dempster for always setting up rounds. In front of you, you'll see a QR code. Please take a picture and after the session, fill out feedback, both from the session itself, but also on how we can improve your rounds, like did Mitch order enough pizza? Afterwards, we're going to have our speakers do their presentation, and then after lots of time for questions, which is very important. So today's talk is on menopause in modern medicine, and we have two amazing experts here speak with us. I'm going to read their bios and then introduce them to speak. So first, we have Dr. Alida Pokoradi. Alida is a gynecologic oncologist at the Royal Victoria Regional Health Centre, where she offers surgery and systemic treatment for female pelvic cancers. She has academic and personal interest in menopause and gynecologic cancer survivorship. Alida is a certified menopause practitioner by the Menopause Society, formerly the North American Menopause Society. She completed medical school and OBGYN residency at Queen's, and then moved to McMaster University for her fellowship in gynecologic oncology, finishing in 2023. Prior to medicine, she did a Master of Science and a PhD, because, the first wasn't enough, at the University of Aberdeen in Scotland. Her Master of Science examined the risk factors for early natural menopause and cervical menopause. Her PhD work continued to examine the risk of morbidity and mortality related to the early natural menopause and cervical menopause. Alida joined the incredible team here at RVH in 2023 and is excited to use this platform to expand awareness and advocacy for all people transitioning through menopause and the medical physicians who support them. Dr. Beatrice Seguin is a PhD in pharmaceutical sciences, and she dedicated her career to advancing equity in health and beauty. Her work has taken her across the USA, Africa, Asia, and Latin America, with research published in journals like Nature and Science. Those small journals. Proud and rooted in her Latin American heritage, she co-founded MOB Beauty and later founded Estra, a women's health brand focused on midlife and menopause. Her mission is to empower women and promote equity in health. She has a wonderful podcast this time of the month, where she champions evidence-based women's wellness, fostering a community of empowerment for women in midlife and beyond. Make sure you follow her on Instagram. You'll see the link in her presentation. So let's give a round of applause for two people.
Can you hear me? Okay, great. Good afternoon, everyone. I'm left-handed, maybe that's.
Yeah, some of that journey is tough, and so if you don't know what to expect, it's even harder. Basically, you're going to get blindsided, and that's the part that I think is really unfair. Is, for some people it's a really easy, smooth transition, and for others there's some challenges along the way, and it would be helpful to know what to expect.
Why don't I get my menopause support package delivered on my porch? A bit more about what to ask for support, but I don't even know what I'm asking for.
Some of that journey is tough.
If it works.
Delivered on my porch. A bit more about what to ask for support, but I don't even know what I'm asking for.
It doesn't seem to want to play the rest of the video. The third guest in this video is Aura Sofia. She is a newcomer to Canada from Colombia, and she shares her insights. She is a healthcare expert. That this issue is not just in Canada. In South America, Argentina, plenty of studies also published to show that when surveyed, over half of the population didn't even know words like perimenopause or menopause and what it is. And that is where my story began 2 years ago, with respect to talking to women in our community, not just healthcare professionals, but the women who've gone through it and are going through it, and the ones who don't know they're going to be hit by that train real soon. And it's not just in our backyard. It's not just the women in our community. If you follow popular culture and know Halle Berry, she is very public and vocal about the fact that her perimenopause was misdiagnosed as a severe case of herpes. Can you imagine the stigma attached to that? And more importantly, the fact that that was not the underlying reason for her symptoms, and therefore she was not receiving the care she needed. It's no wonder that studies show that over 70% of women in midlife feel patronized or invisible, not just in our healthcare system, but everywhere, even with respect to brands. Okay? We sell crop tops to our teenagers or frumpy clothes to our grandmothers, but not much in between. My journey with the word and understanding of the word perimenopause and menopause began with a negative pregnancy test. Because in my mind, I was way too young in my early to mid 40s for a missed period to mean anything other than pregnancy. So once I realized there is something called menopause and perimenopause, and that it does not happen later in life in one's 60s, I wish someone had a proactive conversation with me in my mid 30s and showed me this graph. Because turns out women or people who menstruate can spend up to 1/3 of their lives in this phase. It's 3 phases. Menopause itself is just one point in time when you reach 12 consecutive months without your period. Everything after is postmenopause. And some people will tell me, hey, I went through that, I'm fine now. But what we don't realize is in that postmenopausal phase, we have an increased risk of certain, we have risk factors for other diseases related to the menopause. The thing that blindsides most people to this day is that phase called perimenopause, which can be up to a decade before your menopause birthday. And in today's society, that can overlap with having your children, because many of us choose to focus on studies, career, and we can be having children in our mid to late, even early 40s. And so symptoms like cramping, vaginal dryness, weight gain, despite exercising and doing the right things, mood swings, loss of libido, are related to our loss of estrogen, progesterone, and testosterone. But most of us don't connect that dot because we haven't been taught about this phase of our reproductive life. And so for me, once I realized that, in fact, this is why I was feeling the way I was feeling, not right, not like myself, not sleeping well, gaining weight in places where, like, where's this coming from? I went down a research rabbit hole, and I'm lucky because I'm a PhD in immunotoxicology. I can understand primary literature, and I realized I didn't have to suffer. I didn't have to put up with some of my symptoms. And for me specifically, I concluded that menopause hormone therapy was one tool in the kit that I wanted to consider. But when I brought this up with the 2 people I trusted most, my husband, who's a medical oncologist here, and he's in the room, and my primary care doctor, who is a wonderful doctor, both of them discouraged me from menopause hormone therapy. Why? Well, my husband is Gen X. He went to med school, got very little teaching about menopause, and also became an oncologist and was raised around the negative lines of the Women's Health Initiative, which back in 2002 made news and published that there was an association with increased risk of breast cancer with hormone therapy. And I'm not going to go into the details of the WHI. If there are questions, Dr. Pokoradi can address them, I can too. But the point is more about the fact that a very highly trained, intelligent, capable, caring husband who happens to be an oncologist and a very caring physician both held this belief. They did not have up-to-date information. Number two, and I'm going to throw them both under the bus, and one's a woman and one's a man. We often make decisions for our patients. The reasons might be, there might be many, right? You're in clinical practice, you don't have a lot of time, you're not going to go into necessarily a lot of details. But there is also a sense of misplaced, patriarchal, I know better. And, I consider the risk for you, and this isn't for you, versus the actual conversation of risk benefit for whatever treatment is being discussed. And not all care professionals are this way, but it is a repeated story. It is a common theme I hear every day from the community. And so for me, the fact that I had the education and let's say the grit to not accept status quo, I had to convince two people in my life that it was the right thing for me, that it was worth, the however small risk compared to the potential benefits was something I wanted to consider. So eventually I did get on that path and I realized, crap, menopause hormone therapy doesn't cure everything. I still feel really lonely. Why am I questioning my self-worth as a woman? Why do I feel like crap? Why do I think I am past my prime? That has nothing to do with medicine, but a lot to do with the societal messaging we receive and a lack of community, frankly. And that's when I set out to search and then create a community. And the reason we need community, as well as evidence-based support, is because 1 billion of us are going to be going through perimenopause by 2025. It's actually a little higher than 1 billion now. But can you imagine 1 billion women at the prime of their careers and work contributions feeling dismissed, confused, alone? That is not right. What are the implications? Societally, there are many, but we're at RVH. You represent an amazing workforce that supports our communities. And so what does that look like for a place like the RVH or any workplace? I wonder how many of you in the hospital and the regional hospital around Barrie are women who menstruate, going through perimenopause or menopause, and are facing cognitive changes, feeling stupid because you're blanking on that word that you've always known, but all of a sudden can't recall. How many of you have mood changes at home and at work that impact your personal and professional relationships? How many of you show up to your shift exhausted because you couldn't sleep, because your night sweats or your anxiety are affecting you tremendously, but you can't talk about that? Or so we think. How many of you have experienced embarrassing hot flushes at work? Is there proper support and accommodation in the workplace for women going through this massive transition? Now, the impact of unmanaged perimenopausal and menopausal symptoms in the workplace has been published by Dr. Seguin et al. In the Mayo Clinic Proceedings in 2023, because we're finally paying attention. Okay, and we're starting to study things and publish, write about it, talk about it. Even Oprah talks about it now. But 13% of women report at least having at least one adverse work outcome due to unmanaged symptoms. 11% reported missing work in the preceding 12 months. This is an American study, but I'm pretty sure it's translatable globally. The Menopause Foundation of Canada recently published a report showing that 10% of women leave the workforce due to unmanaged symptoms. Again, we represent a tremendous asset to our workplace, to our community, to our society. What a lost opportunity. If I haven't convinced anyone on the health equity front, it also makes good business sense to support women in this stage of life. Perimenopause-related symptoms that impact productivity represent a lost opportunity of $150 billion globally. Now, why do we feel lonely and confused? I've alluded to the fact that there's some outdated information or misconceptions related to things like the WHO and others, despite very clear, very evidence-based guidelines emitted by respected organizations, including the menopause societies. But there's also societal messaging. When we hear things like she's past her prime, or when we ourselves say, I'm having a senior moment, or 50's the new 40. Why isn't it okay to just be 50 or 60? 60's the new 60. Women on top of all of this carry a triple burden, often talked about, but still not many solutions. We work at home, we work at work, but we carry the emotional burden of everyone around us because somehow that's what we're supposed to do. And all of this is with a loss of community because of the way society has progressed. We are more siloed now. We don't live with grandmother, great-grandmother, great aunts, right? So we don't have that sisterhood, that whispering, that encouragement, that this is not negative. It's a transition that needs support. And the questions women have are ones they shouldn't be asking alone. They're actually things that should be proactively brought up. And I mean in a clinical encounter, when you have a checkup, why wouldn't we be asked, hey, does sex hurt? Because if you notice sex hurts, there's solutions for that. I've never been asked that in my clinical encounters. Why do I have low desire? Aside from the fact that when the dishwasher does not get emptied for me, okay, but why biologically is it happening? Is there something I can do about it? Beauty and appearance, it sounds trivial, it sounds vain. It is not. We all hold an identity. We don't like it when our hair is thinning and balding, or when our belly starts expanding despite doing the right things and not realizing actually we have to do things differently at this stage of life. You know, it's tough. Just exercise and eat some protein. No, there's more to it than that. Mental health, the impact of mental health, the rate of divorce, depression, suicide in this stage of life. These are real consequences. And of course, sleep and fatigue. They're all interesting. And these are things that should be addressed in a more proactive way. Now, women over 50 have been dubbed by Forbes the super consumers. They hold $15 trillion in purchasing power. So if anyone thinks that you don't have power, you have power. You have power in how you vote. You have purchasing power. And if these women are told platitudes like, hey, just dress in layers, eat more protein, move your body. Have you tried drinking wine before sex? And I'm not making this up. Women have been told these things, and sometimes by care providers, okay? Not just friends. If this is what they hear, they're not going to accept them. This new generation of women, they want to feel better. But if they're not offered evidence-based support, what will happen is they will walk through the grifter door. I call it the grifter door. Okay, there are plenty of solutions out there, diets, diet fads, books, supplements with no evidence. But if I think that's the only thing I can try to help me sleep, I'm gonna try it, right? So we do not want that. We as a society and as a healthcare system need to make sure we offer women all of the options that Dr. Pokoradi will tell you about. And in addition to the medical options we need to be offered, all of us, men and women, menopause is not a woman's issue. Menopause is a human issue. We need to change narratives together. We need to stop looking at aging as a negative. We need to look at menopause as not being taboo or past your prime. And we certainly have a right to claim that word beauty. It is not just for the young. Beauty is something we need to feel. But the only way we'll change the narrative, in my opinion, in addition to the support of our healthcare system, is through community, is through women who help us bust some myths. And that is why my podcast is so important to me. And it's being filmed in your backyard here in Simcoe County, where I invite professionals, experts, but women who can help tell us aging doesn't have to lead to poor health and disability, like Lori, who just ran a crazy 42-kilometer race at 64. She's in the room and she's an amazing supporter. Like Janine, owner of a very successful company in Toronto called Tonic Living. Some of you might follow her on Instagram or buy some of her home decor, who breaks that concept that we have to take care of everyone first before we take care of ourselves. The oxygen mask needs to go on ourselves. Self-care is not lighting candles and taking a bath. You have to be radical in your self-care. It's self-advocacy, but it's also taking time for yourself, whatever that thing can be for yourself. Dr. Jessica Green, who practices in Aurelia, who very simply but boldly said, menopause is normal, but it is not normal to suffer in silence. It is not normal to deny women access to care because it exists. And Seguin, one of my wonderful recurring guests on the show, who reminds us that you can do whatever you want at whatever age you want. And don't worry about what society expects of you, especially not when it comes to expressing yourself. And so if I leave anything with you today, is that I want you to know, as a practicing clinician, please remember to give women a sense of agency, intelligence. We are not dummies. Tell us what the risks and the benefits are. Have a conversation with us, but the decision ultimately belongs to the woman. Give her options. One size doesn't fit all. One size doesn't cure all, but go through those options. And to the women, I want you to know, embrace your age at every age, which is really hard to do. But the more you do it, the more you stand in your power and model for the younger ones. And Dr. Pokoradi will tell you about all of the ways to not suffer in silence, but I have a prescription for you today. And my prescription is, whether you're single or in a long-term relationship, I want you to fall in love with yourself and realize that your 80-year-old self will thank you for being radically focused on yourself and making sure that you grow in power and in health and in beauty. So if any of this resonates, please do follow this time of the month on YouTube or where you get podcasts. If you'd like to contribute to the show as a provider or a community member, these are my contacts, and thank you.
Amazing. Amazing. Oh, thank you. Hi, everybody. I'm Alida Pokoradi. I'm one of the gynae oncologists here, and I have no idea how I'm going to follow up that presentation. Beatrice has been an amazing friend and colleague to get to meet here, and she does amazing work because I feel like if people like her are let down by the medical profession, like what shot do like regular people have? Like she's like extremely intelligent. What about people who have no idea, who don't have already like such an amazing understanding of medicine and basic kind of pharmacology? Like what about everybody else, right? Like I feel like we've kind of we have a lot of building to do. Anyway, here I do like my introduction said, I do chemo, I do surgery. Today, I said yes to this presentation. I didn't know that I was in the OR today, so apologies that I am not as well dressed. But yeah, so we're gonna get started. So some of our topics a little bit overlap between Dr. Seguin and me, but we're going to talk about why should we care about menopause? Yes, I agree. It's a human issue. It's targeted into OBGYN residency a little bit more now, and hopefully in family medicine, but it applies to everybody. We're going to talk more about the symptoms. I'm going to spend a bunch of my time about current guidelines, state of the science, about menopause hormone therapy. We'll talk a little bit about alternatives to estrogen therapy because everybody's always keen, but hopefully I will convince you by the end of the talk today that if you're eligible for estrogen, do that. That's the better way to go. We'll talk about something that's coming down the pipeline, and hopefully the Canadian government get some approval going soon for a really promising treatment. I'll talk about testosterone because it's something that's become extremely hot topic lately. And we're going to talk about how can we do better for our patients and kind of help set the stage so they can thrive in midlife. So why should we care? So Dr. Seguin, I also will apologize. I never fancy up my slides, and her slides, I saw them, I was like, these are gorgeous. People are we are an aging society. A massive proportion of our life, if we're lucky enough, that's what I always think of. It's like, if I am lucky enough to experience the menopause, and then if I live a normal life, an average Canadian woman's living till around 84, and that number is still going up. So if an average age of menopause in Canadian people, is 51, like I've got 34 years, like 30 odd years before I finally die in the menopause. Like that's a long time. And it's only going up. So as Dr. Seguin said, like this is going to matter. And sometimes to get people to care, you have to realize there's going to be a financial burden to everybody. And I don't know, when I don't come to work, the work doesn't get done. Maybe there are some jobs that aren't like such, but people will have to fill these roles. Like it is going to matter, and it's going to be a ricochet, like absolute domino effect if people can't just do their work. So there's just, I don't understand how the lost productivity and lost income to employees is not quite the same units, but please don't come to me for any financial advice. That's for sure. One thing I will say is the Menopause Foundation did an excellent survey where women, or speaking broadly, anybody that experiences a menopause, I want to be inclusive always. Some people who can't cope are trying to basically hide, and it's creating all of these lost opportunities. And we'll talk more in a sec. So menopause symptoms, I feel like anybody, if I stop someone on the street and said, name me a menopause symptom, they're probably going to say hot flashes. And if I asked them for 3, I feel like they'd probably be struggling to get numbers 2 and 3. There luckily is a symptom tracker. So Menopause Foundation of Canada, anybody, if you just sign up for their emails, they say, thanks for signing up. Here's a menopause symptom tracker. And it goes on to 4 different slides. So this is the first slide. There are 30 amongst these different slides. So these ones are the physical ones, which I think that we're probably best well-versed in. So hot flashes, night sweats, some people call them flushes, whatever. Changes in periods, like by definition, that is how menopause is going to present itself. 12 straight months of no period equals menopause on, I love that, the birthday of your menopause. It's a new start. Body aches, super common. Fatigue, extremely common. And you can see how a lot of these things start getting tied together. And I would be shocked if someone only had 1 symptom or 2 symptoms. They're probably going to have a host of them. Skin and hair changes, heart palpitations, dry eyes, dry mouth, dental complications. Mood and mental health. Fortunately, I feel like we're finally starting to pay attention. Anxiety, the nervousness, loss of confidence, depression, low mood, like crying, jags. I feel like all of those are so intertwined. And it's just, if we're not helping patients to see this coming, when it starts happening to them, like you can see how it's only going to snowball, does not empower these people to thrive. Next, so very much matters for quality of life. So these are things that aren't going to kill you, but it might feel like they are. So is sex painful? I agree. Like sex is a common human experience. Everyone has sex, but is that normal? Like how are things going? And all of these are relevant too. They're changing because these are all estrogen responsive tissues. Like the vagina has estrogen receptors. Like the vulva, by the way, just a shout out for the vulva. The vulva is the outside of everybody. What people commonly call the vagina. The vagina is only like the tube. That's literally it. Like, please call it a vulva. It's not a bad word. It's just anatomy. My 5-year-old boy knows what a vulva is. And now his kindergarten teachers do too. And then the other thing too, bladder infections. I won't get into nitty gritty, but the bladder also has estrogen receptors. Recurrent bladder infections are classic for lots of people in the postmenopause. Is it normal? No. Can we do something about it? Absolutely. Cognition and sleep. You can see how all of that confidence definitely comes into it. And how is anybody going to be performing their best if all of this is going on, right? So, and sleeping poorly kind of only begets more of all of this, I can only imagine. Okay, so Dr. Seguin is so, you don't hurt anybody's feelings, but there are lots of people, if you have Instagram, there are some pretty famous gynecologists, a urologist who are on Instagram, who are kind of flooding the masses with what I initially, when I was like, oh, awesome, these people are talking about menopause. And then I was like, wait a second, what is happening? Because how is this, you're a gynecologist, you're not a dietitian, and you're not a gastroenterologist to be writing a whole book about a diet. I'm not sure where things are going there. Or like Dr. Seguin was saying, this is normal. This is so normal. And we don't need to replace what is going to be just naturally lost with time, because it's implying a deficit and that something's wrong. It's like, no, this is just it. Like ovaries don't work forever. And eventually they're going to stop making estrogen and some other hormones. So what I just teed up here is that the misinformation that's just in the social media right now and further abroad it's kind of running rampant. And in September, last month, the Menopause Society, so yeah, formerly NAMS, had a meeting, and they were pretty concerned because some of these Insta-famous people are saying, well, actually, those guidelines are outdated. And they said, actually, no, they're not. They're not. Everything is actually what is there, and they are public. Like you don't need to pay like $60 for an article. Like anybody can Google these and find them, which is amazing. And how empowering to know that, yeah, this is free, but the patients, like, first of all, yes, it's written in medical language, but if they knew it's there, that would just be so incredible. The thing I highlighted, so few people are actually using hormone therapy, like less than 4% of eligible people. And you'd think that number should be, or probably would be a lot higher. Just some food for thought. So current guidelines. So now we're just kind of going to launch into medical stuff. So apologies if it gets a little bit less interesting. So I feel like the start, it's like, oh my gosh, like as a clinician, you think, oh my God, this person's telling me that they're in menopause. Okay, she's 50. Like, do I have to order labs? I'm not sure. What do I have to do? And then basically the rule of thumb is she's telling you she has menopausal symptoms. I just showed you a list of 30 things. Probably what she's describing are on that list. The other thing too, it's like, if she's telling you her periods have gone away, well, she's kind of teeing herself up for the menopause. And you don't have to order labs. It's so simple. It's actually kind of beautifully straightforward. Unless you think, oh God, are her hot flashes because of, I don't know, some weird cancer diagnosis? In which case, like, okay, you probably need to follow that up and totally flesh that out to make sure you're not actually missing something that you are misassigning or attributing to the menopause. Pregnancy. So yeah, Dr. It's like, don't forget a pregnancy test. It's totally possible. Same thing, like 50% of pregnancies in Canada are unintended, which still seems completely nuts to me. I don't deliver babies anymore, but how can we not anticipate this? But anyway, if people are young though, it's like, okay, menopause can happen early. Like There's also, as a complete aside, a really strong genetic component. My mom was super young. It is around the corner for me, and it's not going to be a good time because hot flashes, severity, frequency also probably has a really strong genetic tendency. So memories of me coming home from high school and her just being in her underwear in the kitchen saying, "Don't touch me, I'm having a hot flash." Anyway, in young patients, you want to say, okay, this gets a lot more interesting. So what I've just kind of put here is just the surface of the iceberg. So an FSH, follicle stimulating hormone, basically it's the signal from the brain that's telling your ovaries, hey, like pop out an egg, try to ovulate. The thing is, FSH goes sky high in menopause. Our brains never stop being optimistic that another egg might happen. So the FSH goes crazy high. It fluctuates though. And so a single point in time of FSH is not always the most helpful thing. You have to put it into context with an estradiol. What makes estradiol? Eggs. Basically, like a developing follicle will crank out some estradiol. And so it can help you say, oh, okay, she's like at a part of a cycle of her menstrual cycle versus the FSH high, estradiol is low, and you can think, okay, she's probably getting close to perimenopause or is postmenopausal, depending on certain values. AMH, anti-Mullerian hormone, is another hormone that basically decreases with time. AMH is kind of an awesome test. It's really helpful for like people that do infertility, for example, as you say, what is their ovarian reserve? Like how many eggs are waiting in the wings to be ovulated? Over time, we see that number decline. The one useful thing about AMH is people can be on birth control pills and you can still test it. Whereas FSH and estradiol, by definition, like you are altering these things with a contraceptive, so they're not as reliable, or they are not reliable. My personal beef is AMH, often patients have to pay for it. Please just let them go somewhere where it is free, or just say, is this actually indicated? Because I don't think we should be also financially burdening our patients amongst taxing our broken healthcare system. Other things exist. I'd say ask for help if that's happening. So then the next thing, it's like, okay, so depending on the age and can I give her hormones? Well, what are reasons to actually give someone hormones? Because I think this is where some of that misinformation in social media starts coming from. Who should we not give hormone therapy to? And this is something where I feel like people think, oh my God, can I actually combine systemic and local hormone therapy? Yes, yes. So systemic treatment, so whether it's a patch, a pill, like a gel, whatever, it's never going to reach high enough concentrations at like the urogenital levels to make it a happy vulva, vagina, bladder. It just won't. So you do need to add on local estrogen as well, or a local hormone, I should say. We're already running out of time. There's so much to say about menopause. It's a crazy topic. Okay, so what are actually guideline approved indications for hormones? Someone that has hot flushes, the fancy name is vasomotor symptoms. The previously known as atrophy, which was just such a short, sweet word, but it has so many connotations. The genitourinary syndrome of menopause. So it also gives a shout out to the bladder in there. People who are going through the menopause very early, so in their 30s, it's called primary ovarian insufficiency. And then a singular kind of health indication is to prevent bone loss and to reduce fracture risk. It's not to prevent aging. We cannot. We're all mortal. We can't reduce cardiovascular risk. At least we don't have any studies right now in people that are going through menopause at the average age, around age 50, 51. Or on that same note, to prevent, like to improve your brain health. Like, I don't know, I've signed up for the New York Times crossword and that seems to be working okay for me. So who should we not be giving these to? This is actually a narrower list than like oral contraceptives, which I feel like people are pretty comfy with ordering, or at least if you're not, please ask a friend and get some help there. But first of all, this one always gets me, and especially as a gynae oncologist, unexplained vaginal bleeding. I hope it's not going to stay unexplained for very long. Like, please examine your patient. Oh my God. Personal history. or an inherited high-risk thrombophilia. So that's like some kind of a clotting disorder. Those sometimes come to light through pregnancy. Sometimes you find it, through the family tree and just everyone's clotting here and there. Someone with an active liver disease that's actually causing liver dysfunction, so be it cirrhosis or they have abnormal liver function tests. Someone who's had a previous stroke, heart attack, or a blood clot. And anything that I've put a little star asterisk beside, it means it's actually kind of not true. Actually kind of not true. A prior estrogen sensitive cancer, kind of not true. Migraine throws everybody off. You can give people with migraines hormone therapy. That's okay. So the star, what I would say is if you are somebody who is not comfortable with prescribing hormones, please actually stick to the previous slide. I don't know how to go back. Please actually just stick to this. But maybe while you say, you can also say like, I'm checking with other colleagues, whatever, specialist, to say, okay, like, do we really need to add in, like Dr. Seguin said, like that paternal element or not? Because a lot more people qualify for hormones than we probably think. Like, for example, people who have a personal history of having had a blood clot who are on anticoagulation can safely continue hormones. Their anticoagulation is going to like negate the effect of the hormones. This is also true of contraceptives and people who are able to get pregnant. And I would just give an extra shout out for that population because some anticoagulation therapies are teratogenic. They can cause abnormal pregnancies to develop. And so let's look out for everybody and just give everyone the best care because we all deserve it. So this is a trial that was looking specifically in patients who have already had a blood clot, who are on hormone therapy. This included both menopause, hormone therapy, and oral contraceptives about recurrent VTE risk. And essentially, it kind of zooms down that there was about 3.7 and 4.7% clot risk per year from no hormones to yes to hormones. And it wasn't statistically significant, that difference. So it essentially was the same. So the key point is you can keep going. That is okay. Next, what about high-risk populations? So this is maybe getting out of that kind of primary care area into patients like I treat, so gynae cancers. Lots of my patients have an estrogen receptor positive tumor. That's just kind of the way most of those things work. And I'm in the OR taking out ovaries today. It's very hard not to have your ovaries taken out by a gynae oncologist depending on your cancer treatment. Other patients that obviously are always being thought of are breast cancer patients. But no cancer, like cancers are such a mixed bag. Breast cancer, there's not one breast cancer, there's lots of different kinds. And not to say anything of grade and stage, but just the sheer kind of nitty gritty molecular look of a tumor, so receptor status, really matters. So I'll talk more about that in a sec. And for patients who have an estrogen receptor positive breast cancer, often part of their treatment is being on an anti-estrogenic therapy. So like they said in my introduction, we're curing people of cancer, or at least that's the goal a lot of the time. Like, what for if we're not going to help them to live an awesome life afterwards, right? So that's why I figure we got to give people better menopause care. So there's a guideline for that. This is from 2020. And embarrassingly, I only knew that this existed starting last year. But basically, so the Society of Gynae Oncology is basically my Bible. And this is a position statement that is also endorsed by what is now the Menopause Society. So this all together, and we'll get into some of the details, but this is, I thought it was free, but then I realized someone sent it to me and I couldn't unhighlight this. So it's not highlighted because I want you to look at this one particular thing. I couldn't get rid of that, I'm sorry. But this is going through, we've got uterine cancers, most common cancer that we treat. So often these are early stage, they're limited to the uterus. Those patients can actually have hormones. It's amazing. It is literally an estrogen receptor tumor because most most often it's like estrogen exposure is the risk factor. But because most of these people have such an awesome prognosis, you give them hormones and it doesn't actually change their recurrence risk. Or we can still do what's called salvage therapy, which is still a curative intent treatment in a recurrent setting. Patients who are advanced stage, so maybe they have lymph nodes involved, they have further metastases, says that hormone therapy is not recommended. Uterine sarcoma, hormone therapy not recommended. Again, sarcoma is a bit of a mixed bag. There are ones that are definitely related to estrogen, and this may, anyways, talk to your patient is what I'll say. Then we get into ovarian cancer. High-grade serous ovarian cancer is like the bread and butter ovarian cancer, the silent killer, what have you, where most of these people have an estrogen receptor positive tumor. Most of these people have a pretty abysmal prognosis, but we're actually giving them hormones. And I will admit that we are not giving enough of them hormones. And we'll talk more about that in a sec. There's a weirder kind of ovarian cancer called low grade. This unfortunately often affects very young patients. I just unfortunately had a very young patient diagnosed. And low grade means those cells are just kind of bumbling along. High grade means they're turning over super rapidly, and that's basically they're more chemosensitive as a result. But low grade serous, and then I put a star beside endometrioid ovarian cancer. It says hormone therapy is not recommended. I will stick by no hormone therapy for low grade serous. It's a really challenging disease to treat. But endometrioid ovarian cancer, we're going to talk about more in a sec. Cervical cancer patients often are very young. I'll say there's a split. There's like an early cohort and a later cohort. That early cohort, they're often, if they're having radiation, even our kind of attempts to save their ovaries, we often don't do that great a job because the ovaries get hit with some radiation scatter, or we do what's called transposing their ovaries. Basically, we take their ovaries from their pelvis and kind of tack them up right under the rib cage. They can still fall down. The blood vessels can clot off. We often aren't prescribing hormone therapy for these patients, which is really such a shame. Brenna Swift was one of my study buddies for my Royal College gyne-oncology exam. And I love her dearly. She's an incredibly smart human. And this is the star about the endometrioid ovarian cancers. These typically are low-grade cancers. Again, they're bumbling along. They usually are limited to the ovary at the time of diagnosis. Dr. Swift, in this retrospective study, is looking at, well, did a patient have what's called a fertility-sparing surgery, which means the other ovary is getting left behind, and they're getting to keep their uterus, versus what we traditionally do for any kind of ovarian cancer is a total hysterectomy. Total hysterectomy is only meaning removing the cervix and the uterus. There's no implication about the ovaries or the fallopian tubes, but those are going to come out too, and plus some extra stuff often, like lymph nodes. Basically, Dr. Swift is saying that fertility-sparing patients do amazing. Their 5-year survival is actually 100%, whereas it was something like 92% for patients that had conventional surgery. So it's like, oh, okay, like maybe we don't have to be so extreme. Radical is an oncology word. We don't have to be so radical here, because what I will say is these patients, they even tracked pregnancy outcomes. Pregnancy is a high estrogen state, like higher than any menopause therapy. The other thing too, patients that are going through IVF, that is super high hormone therapies to manipulate physiology to get people to crack out a bunch of eggs all at the same time. But anyway, so I think even still, recognizing that guideline from the Gyne-Onc Society is, for me, I still have to be really critical of the literature and still talk to my patient. So BRCA, I wish this was called OVCA, but anyway, breast cancer, the mutation BRCA has a huge association with breast cancers, ovarian cancers, pancreatic cancers, prostate cancers, but I don't treat people that are born male. People who have a BRCA mutation, like in the cells that make them, if they're going to have a breast cancer, they're more likely than a non-BRCA mutation carrier to carry or to develop what's called a triple negative breast cancer. And we're going to talk a bit more about this in a moment. Triple negative is it's kind of throwing back to what I was mentioning about the receptors. So estrogen receptor is negative, and I'll talk more about that. Progesterone receptor and HER2, which is a target for treatment, is also negative. So this is another table from my gyne-onc guideline. And I'll just, so people who have no personal history of breast cancer, they have a BRCA mutation, there are preventive treatments they should undergo that have no bearing, well, they'll lead to a menopause because those people should have their ovaries and fallopian tubes removed, but they can have hormone therapy. People who have a BRCA mutation but have a personal history of breast cancer, it says hormone therapy is not recommended, and it cites a 2008 study. And we're going to talk more about this now. Lynch syndrome is a cancer syndrome that can increase the risk of endometrial cancers, colon cancers, also ovarian cancers, a few other things. So this is from the 2008 study, and basically there were 211 or 221 patients where they didn't have hormones after breast cancer treatment versus 221 that did have hormones of some kind. And basically, what was their recurrence? So you can see that of all women, there was an increased risk of recurrence if you used hormone therapy. You had an increase, what's called a hazard ratio of 2.4%, p-value, which can be super confusing. Don't worry about it. If it's less than 0.5, it's probably significant, which is a good thing, or at least there are nuances. But when you actually kind of stratify it out, patients that have had a recurrence after taking hormone therapy, they're actually more likely that they were the hormone receptor positive group, rather than, I recognize these are small numbers. Sometimes we may never get better numbers. So sometimes like crappy evidence is all we've got, but it's better than the absence of evidence, I guess. Versus the hormone receptor negative group had like the hormone, or sorry, HR hazard ratio was 1.8. So above 1 means it's going to increase the risk of death or of recurrence, whatever the outcome is being examined. But that p-value is not significant. So you can't really make you can't infer much about it. So I will just say this again, this was talking about BRCA patients, but this is BRCA patients with hormone receptor positive cancers. So what about this triple negative group? So there was this review that was published 2021, so not too long ago. But basically, it grouped up a bunch of people, and it's kind of nice to sometimes go down a rabbit hole, and you're like, oh, I understand a lot better, but maybe that's just me. And they said, well, even in an estrogen receptor negative tumor, progesterone receptor negative tumor, HER2 negative tumor, there may be other pathways that taking hormones, what we call exogenously, so taking external hormones, may actually still activate pathways that then cause a recurrence, which is too bad. But essentially it sums up to say, we don't know. We don't know. So when we specifically look, and this is a very chunky slide, my apologies, specifically looking at ER negative breast cancer, data is super scarce. ER negative cancers in breast and in, say, like an endometrial cancer, it's actually a poor prognosis characteristic of that cancer. It's already telling me it's going to be a bad actor. And probably, like, how much does it matter that you've added in hormone therapy? It probably would recur no matter what our best standard of care treatment might be. So this was basically to say, this also mentioned the Holmberg study again on line like 7 about that, but we don't have enough information, not really. Pathology matters. I won't be a nerd, but I love this. There's a website called pathologyoutlines.com that's like, I think I love it more than Google. When patients are having surgery, the time from when, say, like Dr. Hanrahan in the OR is cutting out a tumor, before that actually gets plunked in formalin or whatever she sends her tumors off in, whatever time it takes to actually arrive at the lab is called the cold ischemic time. The longer that becomes, it actually affects how the pathology team can interpret the hormone status. I didn't know that. That super matters. So if we're accidentally letting everything fester at room temp for a certain amount of time, and we're changing the way the tumor looks under the microscope as a result, that is not awesome. The other thing too is how they actually in the lab create the slides. That can also change the way the receptors express themselves. So it's like there's a ton more, and there's so much more to say than just like estrogen receptor positive or estrogen receptor negative. What I didn't also put is sometimes negative means less than 1%. It doesn't mean 0. And it's like, does 0 to 1% actually matter? Maybe, yeah. This was looking at giving premenopausal patients hormone therapy. And essentially, this was saying that of all patients with an estrogen receptor negative tumor, there was no significant difference in recurrence. So, and this was from 3 years prior from that other study. I think it's just have a discussion with your patients, recognize I'm going to still be following you anyways. Yes, this may increase the risk of recurrence. We can't actually qualify that, but like I'm here for you and I want you to be living a good life with minimal symptoms, whatever they're looking like. Local estrogen, there's a whole guideline from the Menopause Society about this. And essentially, super busy slide, super tiny words, sorry. But basically it says if they're early stage, if they're probably estrogen receptor negative, go for it. But when you start reading between the lines, kind of just do it. So when they're talking about what I specifically super love, oh gosh. Okay. This starts getting into it. But some people are living a really bad life, even when they're in a curative setting. But especially, please never forget about patients who are actually in maybe like a really bad metastatic setting. Those patients, they are not going to do well regardless. You are not hastening death by giving them hormones. You actually might improve their quality of life by doing so. So please actually just chat with them. But these are all free for everyone to read. Feel free. Estrogen alternatives, we're like super running out of time. So I just want to, there is a statement for that. And basically, it's like using low-dose antidepressants and other things that are essentially all going to help the brain figure it out that the hot flushes will be less in hopes. My personal go-to is venlafaxine. It's generally really well tolerated, and that's my bit. So we're finally getting towards the end, I promise. Why we never talked, like, why do hot flashes happen? I think we kind of just gloss over. It's like they are a thing, but why? So I'm so glad I never became a neurologist. Those people are beyond smart. But essentially, there's some dysregulation in the brain that happens. And a thing that's called neurokinin, and it's the third receptor that I'm about to talk about. It basically, the dysregulation causes that what we call the thermoregulatory zone just to go a little bit haywire, where you feel hot when you really shouldn't. It's just this whole part of the brain is not doing great. So this cool new drug called fezolinetant, brand name is Veozah, is a neurokinin 3 receptor antagonist. This has been approved last year in Europe and the US. And initially, I love history of medicine too. It was initially a schizophrenia treatment, did not do so great, I guess, in the 1980s. There are lots of things that we use for other indications. For example, I use olanzapine, which is a really awesome treatment for chemo-related nausea vomiting. The dose I give them is pretty small, but I tell all of my patients it's actually also used in higher doses for schizophrenia. And it's just because it's a neuroactive molecule. So Wendy Wolfman, name's in the middle on the second line. She is a gynecologist who is like the menopause guru of Canada. And I remember I met with her a few years ago, and she wouldn't be quiet about neurokinin 3 receptors. I was like, what is even going on? Anyway, she was part of the study. And essentially, fezolinetant is amazing. It's a non-hormonal treatment that is helping to seriously reduce. Okay, it's called a Starlight trial. So I don't know why they've called themselves that, but there's Starlight 1, 2, 3, 4, another super busy slide, but essentially is really helping to reduce frequency and intensity of vasomotor symptoms of hot flashes. It's also really well tolerated. So I'll gloss over who they included. Everything's really strict anytime it's a clinical trial, but essentially you can see placebos are in the gray. They had a certain dose until 12 weeks, then they crossed over. They tested 2 different doses. Both were super effective. And basically nobody had a bad experience with it. 6% had a headache, sure. Some people had some elevated LFTs, and 3% had COVID, but I think that was just because of when they ran their studies. It sounds like such a promising treatment. It is about to be studied in breast cancer patients, where it's like, finally, these people are going to be seen. And I figure breast cancer patients are the ones who set the stage for a lot of other oncology care. I'm always really jealous of Pink Ribbon Everything. I had a patient accidentally donate to the Pink Ribbon campaign because she thought it was for gynae cancer on the whole. And I told her, unfortunately not, that was not your kind of cancer. That's okay. But anyway, this is really promising stuff. Testosterone, it exists, but other things we're doing, like giving hormones, estrogen, it matters. So if we're actually giving transdermal estrogen, like nothing exists independently of everything else. When we're giving a transdermal, so basically a sticker on the skin estrogen patch, it's reducing a thing, or sorry, it's having minimal effect on a thing called sex hormone binding globulin, which binds up testosterone. Whereas when we're giving oral estrogen treatments, it's actually increasing sex hormone binding globulin, which is decreasing people's available testosterone. There's also a whole position statement that like the European Menopause Society, North American Menopause Society, everybody has put their names on this, and they basically say it is only indicated for treatment of what's called hypoactive sexual desire disorder, which has like a huge laundry list of different criteria. We should be using non-compounded testosterone. You do have to track blood levels with this because you're targeting premenopausal testosterone. Too much of something is sometimes a bad thing, and that includes testosterone. The other thing too is you have to be mindful that testosterone, an enzyme that just exists in like the periphery of our body, will convert that to estrogens. So if you're trying to avoid estrogens, you're actually still giving them a bit if you're giving them some testosterone. Lastly, bridging the gap. We have to make this easier with patients. I've kind of really over talked. I think we really do have to set the stage for people. Like we tell people they're going to anticipate having a first period. Hopefully most of you got a warning shot about that before you had a bad day at middle school. But it's like, this is like some people call it the second puberty. Like it is going to happen if we are lucky enough to live this long. And so I showed you earlier, there's the screening tool. People are already used to like tracking like PMS symptoms. There's like been a tracker for that since like, I think the 90s. Like we're used to this, where people are used to tracking periods because they don't want to get pregnant or they do want to get pregnant. It is inevitable. It is normal. If you are not comfortable with prescribing any of this, just ask for help. I was going to go through this if I had enough time. MQ6, you can Google it. It's got an awesome flowchart, and it is so straightforward. And it just helps you to understand what are the indications, what are the contraindications, what are standard doses, what needs to be done to make sure everything is safe. What I will always say is another bedside test, looking at the vulva, make sure there's like, what is that looking like? It's probably not herpes like Halle Berry was told. This is an amazing 4-page review, might even be 3.5 pages. It's free, published in the Canadian Medical Association Journal just last year. Michelle Jacobson is an amazing gynecologist with a menopause focus who works in Toronto. And basically this is phenomenal. Like this paper should be in everyone's desk. There are definitely unanswered questions about menopause. I think we currently have answers that we're not using. So maybe we should just start there. Like it's very lofty to look ahead, but maybe we can all just tackle what we already do know and make sure we're using that information wisely. Part of just advocacy, it would be so nice if people could actually afford this. There are some times when I'm choosing a certain, say an oral estrogen over a transdermal estrogen, because the patient just straight up can't afford it. lots of my cervix cancer patients. There's one who I inherited. I took over someone's practice last year. She had her treatment many years ago. She's 26, I think. She's been postmenopausal this whole time, and she cannot afford hormone treatment. And it just makes me feel super sad. BC is like a shining light in our country for so many parts of healthcare. They have just this past year said they're going to make hormone therapy covered, which is incredible. And then Manitoba were like, hey, that looks good for politics. Let's do that too. So thank you so much. I super appreciate being here. Well, I've got the soapbox. Get your pap smear. Like anybody who's worried about estrogen is going to make them have breast cancer. Guess what? There's a screening test for that. It's called a mammogram, and I want you to get it. Any of this, please survive. Please just thrive. You deserve it. You deserve it for your family's sake. Thank you so much, everybody.
I want to thank Dr. Pokoradi and Dr. Seguin for a wonderful talk. Okay, run late when you're talking about this good stuff, so don't worry at all. We have questions. There's a lot to have to go back to clinical jobs, but we're for questions and online. Got a couple, but it's online.
You can email me your questions if you want.
Yeah, and you don't have to be. So I've got one for Dr. Seguin. So what do you wish your prior practitioner had done different?
I wish that, much like Dr. Pokoradi said, I wish there was a book of what to expect when you're no longer going to be expecting. So we are getting so many guides or, check-ins when we have our regular visits. So I wish that when I was, mid-30s, with 35 to 40 page, that there would have been that, hey, this is something you should know. You may not be there yet, but if you're going to be experiencing these symptoms, it is normal, it is related to declining estrogen, come back. If that happens, there are tools. I wish it was proactive versus me figuring it out on my own.
So this is just from personal experience, but say I'm thinking like, hey, I'm perimenopausal, I'm gonna go ask my doctor for birth control because, hey, that probably maybe would stop it. Is that a good idea, or should I just say?
You can, yes, so many nuances. I'd say yes. Sometimes a really easy thing to do is to give an oral contraceptive. It used to be a super common thing. My maternal grandmother had no idea why my mom was suffering so much in her early 40s with all these hot flashes, because she was probably on birth control pills till she was nearly 70. Had no clue. So anyways, times have changed.
How long can you stay on birth control? Because shouldn't they want you to stop?
It is. So there are different kind of expectations, hormone levels of our body. It is a super complicated question, but it's something that people wonder. And so what I would say is, like, it's an awesome question, and it doesn't have a short answer. I'm so sorry. Yeah, I'll leave it. But I'll say, if you are on one, talk with your family doctor, because say, I don't know, you're 45, you're like, I don't know, do I need that? Like, I'll need something, because sometimes you stop it and you're like, whoa, what in fresh hell is happening? And you want to do something about that, but you don't necessarily need the premenopausal levels for as long. But you may need something, right? Like if you're suffering with those symptoms. Yeah.
Any other questions? Okay. This one.
Oh.
So one of my questions was, you had kind of alluded to it previously in one of your podcast episodes, and I highly recommend you go check it out if you have the chance. But your conversation with Dr. Stevens, in that podcast was very candid, just kind of like a fly on the wall, just like a very genuine conversation. So looking at it from like partner support lens, like, do you have any suggestions as a partner, like what supports can be put in place to help kind of guide through that journey, if that makes sense?
That's a great question. First of all, let's raise boys to be aware of the entire spectrum of reproductive human cycle.
let's take the stigma out. Let's talk about what that looks like so that when we see it in our family, whether we're a son, a brother, partner, we can offer support. And the support is not to say exercise more and eat more protein. The support is to say, what can I take off your plate? What can I take off your plate? And I think you're beautiful and your cellulite doesn't matter. And all of those things, in addition to saying, if you don't feel right, make sure you go with the family doctor. It's not in your head. So it's just the basic things of seeing that person and not associating it to just being bitchy, crazy, excuse my language.
Okay, any further questions, and then we'll wrap up, but feel free to get email Dr. Pokoradi so she gets your Instagram account up and running. And follow Beatrice. I agree with you in her podcast and YouTube channel is amazing, so please follow it. Okay, thank you very much, guys. Let me take.